Well, thank you for the nice introduction, Dr. Majmanwar, and thank you for the nice lunch and the invite here as well. So just one brief note, proving that life is a series of trade-offs. Obviously, yesterday was a beautiful afternoon, so I had a chance to walk through Central Park, see the Met, and I was thinking New York is just one of the best places ever. That was balanced by the fact that it took me an hour to get from 30th Street up here to Madison Street, moving through the holiday traffic. So again, life is a series of trade-offs. So getting right into the talk here, I'm going to try and tie this in today, both in terms of how this particular project would fit into a population health and why it would be of interest to a delivery science group. We'll touch on that. But first, the business of disclosures. To my wife's chagrin, I do not have any industry disclosures to present to the group. This work was funded by a grant, an R18 grant, their Dissemination Implementation Program, from the Agency for Research, Healthcare and Research Quality. All right, 3 points we're going to talk about today. First, I'm going to give you the business case for the ABCDEF bundle and trying to give you some context why it would be of interest to a delivery science and population health group as a quality and safety initiative. Second, we're going to talk about some specific applied solutions that we used to help deploy the ABCD bundle, and with a focus on things that would be generalizable to other quality and safety initiatives. And lastly, we're going to try and draw out what some of the highest impact and high yield practice adoption approaches based on our experience with the ABCDF bundle. And we have a small enough group. We will leave some time for questions at the end, but if you need clarification or want to challenge me on any points throughout the talk, this can certainly be interactive, so feel free. Just raise your hand. Okay, so the context for this particular work in the relationship of delivery science. So we have a very large, complex, inefficient healthcare system, and I would say that one of the key benefits of having a population health and delivery science group is we can help solve that problem. Some factors that are enhancing the importance of more efficient delivery science. There's increasing demand for healthcare. The left-hand graphic shows the so-called grain of America, that the percentage of patients who will be over 60 plus by 2030, they will be one of the largest groups. And on the right-hand side, you have the projected growth in chronic and complex conditions. So the yellow line, or the dotted line at the bottom is the total growth of the population. And what you see is a relative increase in growth of those of chronic conditions: diabetes, cardiovascular disease, hypertension. Again, that's not going to be a surprise to a population health audience, but this just emphasizes that the demand for care is increasing, and we're going to have to become more efficient about how we deliver it. Various estimates about how much money is wasted in healthcare. The number that keeps popping up is somewhere between $900 billion to $1 trillion. And this is an article by Don Berwick. It just shows different wedges of the waste problem. And I think some of the specific opportunities that I'm going to be touching on today are in terms of failures of care delivery and then failures of care coordination. So how do we close that gap between what we know versus what we actually do? There's also going to be pressure in terms of the reimbursement system. So this is a graphic depicting the percentage of Medicare programs that will move from fee-for-service to value-based. You can see in 2010 that number was 0%. By 2018, that number will be 50%. And typically what Medicare does, private payers will follow, if not now, at some point. So in terms of all the patients we care for, we really need to start thinking about value-based care. When you're talking about value-based care, you want to deliver practices that are proven to be effective, you want them delivered consistently, and you want to try and minimize complications. And that's one of the sort of the main thrust of the ABCDEF bundle for ICU patients. And just a simple equation to keep in mind is value. That's a term we're hearing a lot, that we need to have better value in healthcare. And there's sort of two ways that you can adjust the value equation. So one is by delivering higher quality at the same cost, or maintaining quality at the lower cost. All right, so we've heard about this a lot, the practice adoption gap, the difference between practices that we know work versus our ability to actually deliver them. There was a famous article by Elizabeth McGlynn that talked about the percentage of guideline recommended care that patients in a large primary care population actually received. That number was about 50%. To my knowledge, that number has not improved a whole lot over the past decade. The other number that we hear a lot is that it takes 18 years from evidence of a practice's efficacy, i.e. aspirin after myocardial infarction, to when it gets reliably adopted. I would say that cycle has probably decreased a little bit, but there's still too long a lag period between the timing of something that we know can have potential benefit for our patients and our ability to deliver it consistently. And really what my day-to-day work involves is helping to close that practice adoption gap. And that is really an opportunity in terms of operational support and operational infrastructure. What can be sort of the business case for a department like this to exist? One of the elements of that business case can be that we can really help support clinical operations in terms of getting the right care to the right patients at the right time. All right, now, do we have anyone that does any work with critical care in this audience? Okay, so there are sharks lurking in the waters of the ICU. ICUs are very complex, dangerous places in terms of healthcare-acquired infections. There are various technologies and things that can go awry in the ICU, deep venous thromboses, irregularities in glycemic control, and just central line bloodstream infections. All sorts of things can go wrong in the ICU. And so what I would say, I'm not trying to add to your problem list, but something that's gaining increasing attention in literature as another thing that could potentially go wrong in the ICU is delirium. Now, like those other practices, that initially it used to be considered that central line bloodstream infections or deep venous thromboses were just something that happened. It was just an unavoidable consequence of ICU care. Delirium used to be put in that category. What I'm going to impart to you today is that with a systematic approach, you can reduce the incidence of, if not the incidence, the duration of delirium, and then also mitigate its consequences with the well-structured bundle. So, in terms of the list of things, how would you garner some resources in an organization for doing this? I'm going to help you build the business case. So this is healthcare utilization project data from 2011. It shows that over a quarter of all hospital discharges involved an ICU stay, 27%, and then that even though it was a quarter of percent of the total stays, it was nearly 50% of the actual cost. So the mean hospital charge in 2011 for those care episodes that involved in the ICU stay was nearly $62,000. Based on the demographic trends that I talked about and also the increasing burden of chronic disease, if Mount Sinai is like our hospital, we can't build enough intensive care unit beds. There's just constantly demand for those. The population we have done a very good job of keeping patients alive, but we've also created a very frail population of patients with suppressed immune systems, all of the sorts of long-term conditions that make them more predisposed to an ICU admission. So this is a problem that you'll see more of rather than less of moving forward. When you're in the critical care environment, you tend to think of specific organ groups and in terms of organ dysfunction. So cardiac dysfunction, renal failure, liver failure, respiratory failure for those patients who are on the mechanical ventilation. What increasingly, we like to think of delirium as acute brain failure. So the specific definition of delirium, specific features of it, it develops over a short period of time, i.e. hours to days. It results in a disturbance of consciousness, and then it's characterized by certain additional features of inattention, changes in cognition, and then perceptual disturbances. Some epidemiology of ICU delirium. So there is a 30 to 80% incidence in critically ill patients. And I know that seems high, but when you actually, a number of cross-sectional studies have confirmed these numbers. The incidence varies according to the type of ICU population. It tends to be higher in medical ICUs. We tend to have a frail elderly population, and lower in in surgical ICUs, where many of those cases are elective and they move out of the ICU quickly. As I mentioned, certain populations, the elderly, those with underlying dementia, multiple chronic disease, have a higher susceptibility to developing delirium. And then there are specific delirium subtypes. So the ones that your nursing staff will typically recognize are the hyperactive patients. Those are the ones pulling off their BiPAP mask, pulling at their lines or tubes, seeing pink elephants on the ceiling. Those patients are easily recognized, but they actually only represent 5 to 20% of the cases. Perhaps a more dangerous subtype of delirium is the hypoactive patient. Those patients that are just lying, where the classic medical student note is patient resting comfortably. Well, how do you know what their mental status is if you're not waking them up? And then there's a mixed subtype of delirium. That actually represents 80% of the cases. There's some evidence suggesting that the hypoactive delirium can actually be more dangerous than that agitated patient that is more readily apparent to the nursing staff. So there are a whole host of deleterious outcomes associated with delirium. And these percentages compare if you had an incident episode. So did you ever have an episode of delirium during your hospital stay versus those patients who did not have an episode? So there's an increase in ICU length of stay, an increase in hospital length of stay, increased time of duration on the ventilator, increased costs and mortality. There's actually a threefold increased risk of death at 6 months if you have an episode of delirium during a critical care stay. And then there's also a growing evidence base of delirium as a risk factor for long-term cognitive impairment. So even those patients, and I would say a similar, a good comparison would be those patients who have had cardiac bypass surgery. In some cases, you never get that higher cognitive functioning back if you've had a period of time on the cardiac bypass machine. We're also seeing that even in patients that would be otherwise healthy, people in their 40s and 50s with no comorbidities, if you have an episode of delirium, you can lose some of that higher functioning down the road. Where this also becomes significant in terms of population health, if you had an elderly patient that had been independent, maybe some underlying dementia, that episode of delirium can be like going off the cliff. And those patients may ultimately, rather than being able to live independently, may require an extended time in a skilled nursing facility or even beyond that, a nursing home. So these are very important things when we look at utilization, quality of life, and then cost at a population health level. So if that wasn't enough, I think we talk about moving to a patient-centered system. Patients, and if any of you have talked to them, many people will confirm this, those patients who have delirium or are in the ICU often describe a PTSD type of experience. And there's been a recognition that in the healthcare system we need to do a better job of creating patient-centered care and also engaging families. And untreated delirium is a problem in that area. So this is a real opportunity to sort of work on modifying the system to be more patient-centric. And so it's, in addition to the financial and utilization concerns that we talked about, this is a very patient-centered issue as well. So as I said, this is no longer, the paradigm about ICU delirium has changed. This is no longer an issue that is just felt to be an unavoidable consequence of ICU care. And we have a set of evidence-based practices termed the ABCDEF bundle have been developed that have been shown to be effective for, again, reducing the incidence of and then mitigating the consequences of delirium. So let's go through the algorithm. So ABCDEF. A is awakening. So what that means is patients in the intensive care unit are often on sedating medications. So you turn off the sedation, let them wake up. Breathing trial. That's reducing the mechanical ventilation support and seeing if they can breathe on their own with a focus on trying to get them extubated sooner rather than later. This really should be ABC squared. There's two C's. C is coordination. So for this to work at maximum effectiveness, you have to have teams working together in an interdisciplinary fashion to deliver the bundle. So for a breathing trial to be successful, the patient needs to be awake, so you need the nursing and respiratory therapist to coordinate that. Likewise, if you're going to do exercise and mobility, you need the patient to be awake and off the ventilator or at a point where they could actually work with the physical therapy teams. So C is very important. C is, the other C is choice of sedatives and analgesics, use of continuous drips, and particularly of certain drug classes, opioids and benzodiazepines. Those actually have been shown to be deliriogenic. So there's been a shift to bolus dosing of these sedatives, and then also use of other agents. So there's something called dexmedetomidine, which is being increasingly used which has shown to have been advantageous in terms of delirium incidence versus some of the other drugs. Now, there's a balancing factor here. Uncontrolled pain is also an issue in terms of generating delirium, and so you need to balance use of analgesia with factors with drug dosing that may be deliriogenic as well. And if you look on the website, there will be other there's different definitions of the ABCDEF bundle, but the components of care are similar. So the D is daily delirium screening, monitoring, and then management. And then the E is early mobility and exercise. And F, at all of these different levels, we want to keep the family informed. We want them to be actively engaged in the care, and then also the support mechanisms after the hospitalization. So the bottom line is, when patients are in the ICU, wake them up, get them off the ventilator, get them moving, and that hopefully will reduce the incidence of complications. Okay, so this is the safety parameters for the ABCDEF bundle practices. Now, one thing that I would note, this is a very nursing-centric type of bundle. And what we found is that there was some concern whether or not the nurses felt they would be able to do this. So if you put in a set of specific safety guidelines for when the individual care processes would be warranted, nurses felt very comfortable administering that. And not only were they comfortable, they actually felt it was very empowering. So you talk to some critical care nurse, they were becoming frustrated with the fact that 2, 3 o'clock, our critical care physicians that actually had a pulmonary clinic weren't rounding until the afternoon. They knew a patient might be ready to wake up, but they didn't have an order to do it. So what we put in place was a standing order with clear safety parameters. And I won't go through these boxes individually because I realize they're hard to read. But the safety parameters have to do with, is the patient stable enough to be woken up? Are they having any myocardial ischemia or any sort of arrhythmia? Is their oxygen level too high? If they met those certain criteria, then that allowed the nurse to proceed with the particular care process. And the feedback from nurses, this is something they wanted to do. You hear about having practitioners being able to engage patients in practice at the top of their license. This allows our nursing staff to do that. And it's with these clear safety parameters and well-established safety parameters, this is what also allowed us to to get buy-in, I would say, from our medical staff that this was the right thing to do for our patients. Okay, so some specific methodology related to our R18 grant, some researcher humor there. All right, so some background. I'm at Baylor Scott & White Health in Dallas, and as was pointed out, in spite of our name, there is the Baylor College of Medicine, which is based in Houston. We have a very loose affiliation with them, and it's very much to this point going to be focused on the basic science and clinical trials area. There's also a Baylor University, an undergraduate university, which is in Waco, Texas. That's about 100 miles south of Dallas. So Baylor Scott & White Health, we are a large, high-volume, integrated delivery network. So we have 43 hospitals and greater than 500 patient care sites, over 5 million patient encounters annually, 34,000 employees with 6,000 affiliated physicians. Most of those physicians operate in a fee-for-service environment, so that can create some challenges in terms of implementation and how you get people to adopt best practices. We have the Scott & White Health Plan, and then we also have our ACO, which is called the Baylor Scott & White Quality Alliance. So currently in that ACO, we have 250,000 lives. Dallas-Fort Worth is growing explosively. 1 million people move to the Dallas-Fort Worth every 6 or 7 years is the statistic I've heard. And with that, so our goal is by 2020 to have 2 million covered lives in our ACO. And so that's, I know that in the New York market, ACOs are just sort of evolving, but this is where we see our population health strategy moving forward. Okay. So we had some success getting an AHRQ R18 grant. This is from their patient safety portfolio, and it was one of the dissemination and implementation R18s. And one of our points in our grant application was that we really need better evidence in real-world settings. So we have things that have been shown to be effective or efficacious in a clinical trial, but where things come short, what does it look like in a large integrated delivery system where physicians are fee-for-service, we only have a small percentage of the patients cared for by teaching teams. Now, how do you really prove whether or not something works in those environments with heterogeneous populations? So we were able to set up a quasi-experimental study design that really had three aims. So one was to show that we could put in the bundle across multiple hospitals within our care system. The other piece, and the second aim, had to do with evaluating the success both of bundle adoption and then also whether or not the bundle worked in terms of improving clinical outcomes. And then the third piece of the grant had to do with the dissemination phase. So both locally within our own system and also creating some tools to help disseminate this work nationally. Okay, so in terms of thinking about how we could do a study design to prove or disprove, or I should say to generate information about those aims, we set up two groups. So we had a basic implementation program. So we did some modifications in the electronic health record. We'll talk about the details of those. And we provided them access to standardized reports. The other arm had to do with an enhanced implementation program. So they had those same modifications and standardized reports. They had supplemental interventions of, we engaged site champions there. They were involved earlier and actually helped us develop the content in the bundle. And they had supplemental training sessions. There were 3 hospitals in each group. We matched traits wherever, as much as possible between those sites, and then we operated the programs concurrently. Now, something from a study design some very practical aspects. So we really had to use a pragmatic study design here in the sense that randomization was not feasible. And the reason why is that in our particular electronic health record, it is not feasible to turn on certain order sets and certain pathways at one hospital versus another. If you turn something on in our particular platform, everything had to be turned on at once. Likewise, you really couldn't randomize this at the patient level because you're talking about hardwiring a set of care delivery processes. So that's not something you can easily turn on and off at an individual patient level. So that's why we had to do this, this quasi-experimental design. What I would say is, if you wanted to take this to the next step, you'd probably want to do some sort of a cluster randomized design where that would be one way to do a randomized trial, and you could circumvent some of those problems we had just with doing this within one health system level. Okay. So again, one of the purposes of this grant was to show that we could deploy this and what would the impacts of deployment be across a heterogeneous environment. Now, typically that's something you don't want in a clinical trial, which has been, I think, a critique of, to date of some of the clinical trial enterprise. You really want to see how things work across diverse populations. And the point here is that we had 12 ICUs across 6 Baylor, Scott, and White health hospitals, and it was a cross-section. So we had a rural hospital, we had a community hospital, and we had a tertiary medical center represented in this in the environments. And then within those, we also had subsets of ICUs, medical, surgical, cardiac, within those sites that had multiple ICUs. So again, cross-section heterogeneity was intentionally built into the study design. Eligibility, we were looking at patients who were admitted to study ICUs from July 2012 to June 2015. We were able to operate this program under a waiver of informed consent, and the rationale there was that these were well-established quality and safety practices, and you couldn't really practically obtain consent after the study was complete. Inclusion criteria, 18 years of older. You had an ICU admission lasting greater than 24 hours. And the real benefit for these practices has been shown for patients who are on the ventilator for greater than 48 hours. Because what you'll find if you're to pull the data on your ICU and who was on the ventilator, probably about half your patients get off the ventilator in less than 24 hours. And that may be they're just recovering from surgery, or they had some sort of issue. They may have needed volume removal for CHF or from dialysis, and they get off the ventilator pretty quickly. The benefit of these care processes are for people that are on the ventilator for more than a couple of days. Likewise, once you've been on the ventilator for more than 14 days, you become a chronic respiratory failure patient. they have a different profile. So to keep the study population clean, that was the group we focused on. Exclusion criteria, patients on comfort care. If you were never on the ventilator but in the ICU, we excluded that group. And then primary neurologic diagnosis, brain tumor, stroke, or any sort of intracranial injury, we excluded them. Now, that was done purposely for a clean study population for analysis. Practically, from an operational standpoint, in the last several months, we have decided that we need to actually include that neurologic population because they will potentially get benefit from this as well. So that just sort of balancing what's needed from a research design standpoint versus what is best for clinical care from an operational perspective. Okay, so now the key to getting practice adoption was really hardwiring the bundle. And a friend of mine, Greg Maynard, who's currently the CQO at the University of California, Davis, came up with this chart that I love. It's called the hierarchy of reliability. And if you just tell physicians to do something because it's best practice, give VT prophylaxis because it's the right thing to do, that's what we call the state of nature. They'll get it right about 40 to 50% of the time. That's our baseline use of the bundle before we did any interventions was probably even lower than that. It was probably in the 20 to 30% range. As you add decision support, order sets, other sorts of protocols, real-time reporting, you get increasing degrees of adherence and practice uptake till you get to that highest level, which I call Measure-Vention. And the idea behind Measure-Vention is you identify a process gap in real time and you can intervene on it while it still makes a difference to that patient. So for any physicians in the room, you probably get a report on your performance measure, something like a flu vaccine for patients that have had pneumonia or pneumovax. And I would get those reports. They'd usually be 3 to 6 months after the fact. And I would feel bad about it if I missed a case, but it didn't help the patient at the time that they were in the hospital. So what you really want to do with Measure-Vention, sort of the highest level of reliable delivery, is recognizing a process gap and then being able to intervene on it. Other areas where this becomes very practical, so glycemic control. So if you have an episode of hypoglycemia, that's an opportunity for Measure-Vention, and then DVT prophylaxis in the ICU as well. Okay, so specific tactics that we used to help deploy the bundle. And these things are going to be sort of common features to all quality improvement programs. So activation of nursing and physician champions. As I said, this particular bundle was very much nursing driven. So this was the key group that we had to get buy-in on. Assessment of the current state workflow. That's pretty standard. All the items in yellow really have to do with how we modified the EHR. So development of supportive EHR documentation and order sets, use of a daily rounding tool, standardized performance reporting, and then optimization and refinement of the EHR tools. And we'll go into detail about each of those. Two other specifically IT-related things had to do with training sessions. So we had both, we have a very large system, so we had to use a train-the-trainer approach. And then that was rolled down to the frontline staff. And the other thing that's important had to do with accountability as a system critical care goal. So our Baylor Scott and White Health, our clinical care operations are organized in specific service lines. So there's and I think a good analogy for that would be how departments are structured in other settings. So we have an orthopedic service line, a cardiovascular service line, a transplant service line. And each of those service lines has goals, and the executive leaders of those goals and the physicians have pay at risk for those certain performance metrics. So people start to become very interested in hitting certain quality targets once pay becomes at risk. I know not all environments are ready for that, but in our particular system, that's been a big leverage point. Okay. So from the get-go, the ABCDEF bundle, it has to be an interdisciplinary effort. So you see the list of stakeholders. That's all the way from the executive suite and the CMO down to patient safety teams, pharmacy, your allied health services, PT, RT, and then I think there's an important distinction between interdisciplinary and then multidisciplinary. Multidisciplinary is just getting people together pulling multiple people from different areas. Interdisciplinary really involves getting them to work together. And I'd say to have success with the bundle, it really needs to be an interdisciplinary approach. Okay, so we all love the EHR, I'm sure. I would say at this point, I don't see any scenario where electronic health records are going away. So rather than fighting it and complaining about it, I think we just need to learn how to work with them and maximize what they can do for us. I know sometimes that's easier said than done, but that was one of our take-homes from this particular project. Okay, so the first piece just had to do with activation of the bundle. So historically, in our state of nature, when we just asked physicians to remember to use the bundle and we had that 20 to 30% compliance rate, the physicians actually had to actively find the bundle, click a box, and order it. Because we had those safety parameters and clear guidelines for what the nurses could do and when patients were appropriate for these care processes, that allowed us to work with the medical staff to basically have an opt-out rather than opt-in order set. So anytime there was a ventilator order, this order set, there'd be pre-checked boxes, and so then the nurses would have something to work on. They wouldn't have to wait for the physician to activate that order. And that was, because this was sort of we had that medical staff buy-in, and this was a process that was endorsed by our physicians, that allowed us to do that. Any scenario that I've seen where you have an opt-in order set for a quality practice, you're going to get that 50 to 60% at best physician usage rate. So this is a key step in terms of what triggers the bundle. We also realized that we needed a better job of structured documentation. So if you think of where do people spend most of their time in the modern hospital, unfortunately, too much of it is spent in front of the EHR, typing, looking at structured notes. And if you take the time on the front end to build those structured notes and embed the decision support and put things in a logical sequence, there's two advantages. One, it improves the workflow for the staff that are using those structured notes, and two, it allows you to pull information out on the backside in terms of your analytics. So this is just a specific example of the sedation vacation structured note. We had bits and pieces of this at various spots throughout the electronic health record. So this is an example of what our nurses see and what they would pull out. I realize this is hard to read, but what the red box says is it's titled Sedation Vacation Daily Awakening Trial. Did the patient receive a sedation vacation today? If not, why not? And they need to have a pull-down option. Was it the sedative infusion resumed? If you have a pull-down, and then if so, why? And again, all those questions are things that we can pull out from a structured note on the back end. The other thing is that we put this in a logical sequence. So we put this in relationship to the ventilator-associated pneumonia care processes. This is an example of the structured note that we use for respiratory therapists. Again, did the patient receive a breathing trial today, yes or no, and then it has the appropriate exclusion criteria. So the other thing this allows you to do is you can also do analytics in terms of why patients aren't getting their breathing trials or why aren't they getting their awakening trials. For example, if you knew that the patient wasn't awake enough, you could look at your sedation practices, and that may be a specific QI opportunity for this particular that would help improve uptake and adherence. So the next step has to do with sedation and delirium assessment. So what you have here is a bedside test called the confusion assessment method for the ICU. There's also a CAM that can be used for non-ICU patients. The CAM-ICU is a validated test that was adapted for critical care patients, particularly those who may be intubated and can't speak. So you can actually answer some of these questions with squeezing of fingers or even with eye blinking. And there's two phases to this. So one, you have to assess the level of awakeness. So that's the sedation scale. What we recommend is something called the Richmond Agitation Sedation Scale. It's been validated. It's easy to use. And then if patients are awake enough, so the RAS is intuitive because deeper, more negative levels, -4, -5, those are the patients that are just zonked out. All right, so that's what we define coma as. If a patient's in a coma, you can't make an assessment of their cognition. So that's defined separately as coma. If they're in this green zone, what it means is you can proceed to the delirium assessment piece. And what you're looking for are the different features. Is there an acute change or fluctuating course of mental status? Is there inattention? Is there an altered level of consciousness? And is there disorganized thinking? So if you meet specific features of that qualifies. So one episode of a CAM-ICU being positive, that qualifies a patient as having had an episode of delirium. So that's actually how we define that. Now what we found was that our nursing staff was having difficulty remembering all those features just offhand. So we actually built the decision support for the confusion assessment method ICU. We built that into the flow sheet. And again, this is the same flow sheet we saw earlier, just a different component of it. And it allows you to answer the questions. You can also hover over certain questions, and this card that I just showed you, that'll pop up on the screen as active decision support for our nursing staff. So again, building this in a logical, structured way in documentation areas that the nursing staff use consistently, that was a big driver of practice uptake. Okay. And this is just a similar example of exercise and mobility documentation. Something that we found, there was also an important cultural change related to mobility and exercise. And much of it had to do with whether or not the surgical nurses typically were more aggressive about getting their patients up and moving around. It also had to do when you graduated from nursing school. Many of the newer graduates were just familiar with physical therapy staff being responsible for all the mobility. The New York market may be similar, but my understanding is that nationally there's a shortage of physical therapists. They converted that to a doctoral program in that it's just a numbers game. If you have a 40-bed ICU, there might be 2 or 3 physical therapists. They can't work with every patient every day. And so nursing really has to take ownership as that first line of mobility, and then you get physical therapy and occupational therapy help for those patients who need it. So in addition to the structured documentation there, I think that cultural change of nursing ownership and being really the first line agents of mobility was important. Okay, so I talked about Measure-Vention. So one of the things that we knew we needed was a tool for the staff to get a real-time glance in terms of where their patients were, in terms of the ABCD care processes. So this is a list of all the different viewing screens, and we call these viewers in our particular EHR. So we put that at the top, alphabetically, ABCD comes up at the top, and then just gives you sort of a snapshot of where they're at. Sedation, vacation, spontaneous breathing. This is a very good tool for physicians to round on and see where the patients are at. And what we hope is that it prompts a conversation. If something is missing, why was it missing? This is not the answer in itself, but it's just a tool. So if a breathing trial wasn't done, figure out why not. It may be a very valid reason. Maybe the patient had a radiology test and they weren't going to wake the patient up before bringing them downstairs. But you just need to know that so these care processes aren't missed. So this is at an individual patient level. We also are able to roll this report up so that the unit manager, so you could get a snapshot of what your unit looked like at any given time point, and you could do, say, afternoon ABCDEF rounds to see what care processes may need to be given at that particular time point. And this is just something else in terms of incorporating the ABCDEF bundle in terms of structured team rounds within our ICUs. And then also our nursing staff, at shift change, you typically have huddles. And so this is just, you just see the different elements of the ABCD, an old-fashioned whiteboard, which actually works pretty well as a supplement to the technology. Okay. Training and education, 2 components. We had a super trainer course. So what we're trying to impart there was we wanted our super trainers to be able to teach peers in the CAM-ICU, including teachback. We wanted them to have a high degree of acumen with EHR changes, and also be able to share some case studies with the group, which is a very, very powerful tool for adult learning. Then we had a more basic course for frontline staff. And the idea there was just to really get them to understand the components of the bundle and what the different documentation elements were. Obviously, with 43 hospitals, we can't be doing in-services constantly, so we also developed some e-modules that are available through web-based portals for our staff that they can look at annually for refreshers, and it's also part of the onboarding process for new providers. All right, system accountability, I also mentioned that. So as I said, executive leaders and then physicians had portions of their pay at risk for system accountability, and these were just some of the performance targets that we had. What we decided to do was to develop a point system, and then if we had a certain number of points related to the bundle overall, because we recognize that different hospitals would be at different points, and you're not going to succeed on everything at once, so that different components, there'd be different points to get to the total goal. Okay, so how do we analyze our data? Moving beyond the implementation approaches. We looked at time series analyses to assess changes in bundle use. We examined the impact of composite bundle adherence on risk-adjusted patient clinical outcomes over the entire study period. And so we had 3 groups. So we had a low adherence group, 25 to 50% composite adherence, a medium adherence, 50 to 75%, and then a high adherence group. And you'll see the results from that shortly. Covariates we looked at, age, gender, and we did comorbidities via the Charlson score. We used Apache scores to account for illness severity. And then we had other factors such as time on the ventilator and then surgical versus medical patient status. and then the environment in which they were receiving care. What was the overall ICU quality? We have a global ICU quality indicator that we looked at and incorporated that into the model as well. Okay, so again, one of my points is that don't just hope for a miracle, go for a structured adoption approach. That's what delivery science is all about. All right, so the first outcome, composite bundle intake. So composite bundle has to do with what of all the elements of care that a patient was eligible to receive during their ICU stay, what percentage of elements did they were actually delivered? And so we talked about the two groups, the basic intervention group and the enhanced intervention group. So basic sites are in blue and the enhanced sites are in red. And so what you can see is when we started this, very low rates of adherence, 20 to 30% range. With training and just sort of the community effect of talking about the bundle, we did see some slight increase. What I'll point your attention to is the steep part of the curve. This is when we flipped on, we restructured the EHR documentation and we turned on all supportive IT tools. So very rapid rate of uptake there. And then as we moved into the later phases, this is where we get into the maintenance of accountability and then refining the reports. And so we really feel we've made a lot of progress moving from 20 to 30% range consistently at both basic and the enhanced intervention sites. We're now consistently above 85% with bundle adherence. So we think we made quite a journey. I would say two things related to the rates of adoption. So what this told us was that of all the things we did in terms of training, finding champions, all the classic QI methodologies, the biggest driver had to do with fixing the health IT and fixing the workflow. And I think that's because in 2015, as I mentioned, it's a one-to-one correlation. So that's important. The other thing was that if you had some of our basic sites tended to be high performers in other quality metrics. So the other encouraging message was if you have an ICU that has a good leadership structure and a hospital that's willing to embrace quality improvement changes, you can get this bundle. This isn't something that's going to take lots of external resources to do. Give them the tools, empower them to do it, and those sites that have capabilities will be able to achieve it. Okay, so looking at the different adherence groups, we did see, so this is the low adherence group, medium adherence group, and just some of the baseline population characteristics. What I'll point out is there were statistically significant differences in terms of Apache score and comorbidity. So the patients who were in the low adherence group, their Apache score was a little bit higher and their comorbidity score was a little bit higher. And so we think part of the thing that may be going on is there are patients eligible for the bundle, but they're not necessarily documenting why they would be excluded from it. That's sort of one of the problems you have when you do this sort of design. But again, as best we could, we adjusted for it statistically. All right, so again, accounting for that risk adjustment for illness severity, what happened in terms of delirium and coma outcomes? So a couple of interesting things. So we found that the incidence of delirium, the detected incidence of delirium, actually increased. 1.49 was the odds ratio here, 1.73, and those were statistically significant. So basically, the more you use the bundle, you actually had a higher detected incidence of delirium. What we think is going on here is the detection bias effect. The actual rate and incidence of delirium probably isn't increasing in these units. It's that we're now doing a better job of measuring it. Most cases of delirium go undetected, or many cases of delirium go undetected. So we think by training our staff, they're having a better detection acumen, and that's what we're seeing reflected in the odds ratio. So the message is not that this bundle causes delirium, it's that we're doing a better job detecting it. We did see lower incidence of coma. So basically, the more you use the bundle, by the time you got up to the higher adherence group, the odds ratio of coma was half. And then the percentage, the delirium of coma, and then the percentage of delirium coma-free days, those also moved in directions that you would want to see them with higher use of the bundle. So other than seeing a higher measured incidence of delirium, it looks like there's a positive dose-response effect for those aspects of the bundle usage. Yes?
Can I ask, so when you say coma, how are you diagnosing that? Is that
So coma is defined as a RAS score of -4 or -5. Yep. Okay, other outcomes we looked at. We did not see a difference in ICU length of stay or hospital stay. we did see a somewhat significant, we did see a statistically significant decrease in number of ventilator days. Again, dose response effect higher in the high adherence group. Mobilization out of bed, 2- and 4-fold higher versus the low adherence group. Higher likelihood of being discharged home. And then the inpatient mortality rates were significantly less, so 0.39 and 0.25 compared to the reference group of that 25 to 50% adherence. So because of the nature of the study design, I can't say that this is causal, that actually a higher use of the bundle was responsible for this. But I'd say it's certainly an encouraging sign. And we've looked at some other external data, mortality data in our ICUs. We have seen a positive correlation in terms of lower mortality when we started using this bundle consistently. So you could really only say this was absolutely causal if you had a randomized trial, but at least from a statistical association standpoint, this is very encouraging. Okay, last thing that I'll talk about have to do with costs. So we looked at costs from, we did this at a system level, and so we looked at year 1 of adoption, and these were the different FTE components that if you were just, if you stripped out the research grant portion of this, how much would it cost you to put it in? And these salaries are probably low for the New York market, but because they're U.S. statistics, but cost is about $165,000 to get this, to get the bundle up and running. So that's not a drop in the bucket, but relative to some of the other things we spend, look at your organization's IT budget. This is not too bad. And then what I would say is once it's in place after the 1-year deployment period, you then move to a maintenance phase. It's only about $30,000 to $40,000 a year, and that's really just has to do with the data maintenance and the reports. Okay. So, wrapping this up, in terms of the actual practice adoption, we really view this as a successful application of health IT to facilitate the deployment, the deployment of best clinical practices. Health IT isn't the answer, but to sort of move to the next phase of where we're at in our journey with health IT, I really think we have to recognize that it can be a very helpful tool to help us achieve what we want to do. We observed a 1-to-1 relationship between the clinical workflow and EHR structured documentation and clinical decision support. And what I would say is in 2015, any QI effort really has to get the IT piece, keep the IT piece in mind as a tool to assist workflow. Those hospitals with a strong pre-existing QI acumen were able to leverage the EHR modifications with minimal support. And then this is important. So health IT is a tool, but the other thing that we noticed is that this person-to-person propagation. So Atul Gawande writes about this. You know, how did they spread best practices in terms of use of treatment for cholera across villages in India? It really has to do with person-to-person propagation. And that's true in terms of healthcare delivery organizations in the U.S. as well. And so what that creates is if you incorporate that with clear lines of accountability and generation of local evidence. So papers have been written about in various critical care journals about the ABCD bundle practices, but what is really very powerful in terms of convincing your providers within your organization is to generate data locally and to share it with them and to show them that it's improving. So once we saw those numbers in terms of the mortality, the mobilization, the patients going home, that has really been sort of a very strong arguing point to say, hey, let's get this done. And we've really seen a lot less resistance once we started to share those data elements with them. And then focusing, in terms of all the things we do in terms of practice adoption, I would say that focusing resources on the EHR modification is an early step. It's not to say don't do the other steps, but focus on that first, because in many places you'll have a waiting queue to actually get the IT pieces fixed. That is, at least for this particular practice, and I would suspect many others in the ICU, that's a very high yield adoption approach. Okay, clinical implications. Higher use of the ABCD bundle, ABCDEF bundle across a real world setting. And again, in this case, we built in purposely heterogeneity, was associated with improvements in several patient-centered outcomes. As I mentioned, what we really think is going on in terms of the actual rate of delirium incidence was that we were unmasking undetected cases. And so that's something that we've got to flesh out a bit more. We really think we have an ongoing opportunity once delirium is recognized, particularly working with our physician providers in terms of how they intervene on it. Limitations of the study basically center around the non-randomized design. There may have been some unobserved confounders. As I said, we were relying on provider documentation, so there may have been some of those patients that were labeled as low adherence. It may have just been they may have had a valid exclusion that wasn't recorded. Just like a core measure, we interpreted those as not being done if the documentation was missing. There are also several collaboratives nationally related to use of the bundle as a best practice, and I'll give you a resource page for those in just a moment. Okay, so dissemination activities. We have built, so what I just talked about in the slides, we have a detailed implementation guide, which is going to be available on the Society of Hospital Medicine website. That's going to go live later this month. ICUdelirium.org, that was built by my colleagues at Vanderbilt. Tremendous amount of resources there, tools, etc. It's a great website. And then the Society of Critical Care Medicine also has their ICU Liberation campaign. And lastly, a closing thought on delivery science. So again, what generated this invite, we were at a National Academy of Medicine meeting that had to do with research being more closely connected to the operational infrastructure. And I can't emphasize enough that I really think that's where the opportunity for delivery science is. Our executives and our operations people, we need to do these rigorous practice adoption approaches and these robust evaluations to help us inform better clinical care. That's a gap that's missing in day-to-day care delivery, and I think it's what, as a group, population health and delivery science has to offer, both for your own organization and then also for the healthcare enterprise overall. And that's it. So I thank you for your time, and I'll entertain any questions.